fully clothed in my PPE. So what do we remember about our anesthetic syringe that we were talking about when I showed you how to assemble it? So we're looking at this. What is this part called here? Thumb ring. This is the finger grip. Well, yeah, finger bar. I think it's all like a finger grip. We can call it all in one. This is the what? The barrel. This is the piston and harpoon. Yep. And this is the threader, right? Where we thread the needle on. Do we remember about the blue needle versus yellow needle?
Yellow is shorter.
Yellow's bigger and blue is shorter. So the number for the blue would be
bigger.
Smaller.
Bigger.
I don't know which one's bigger.
Okay. Let's back up. So we're calling this the smaller needle. So the number would be what? Bigger. And then this number would be smaller. So if we were to look at this, this is a number 27 long. This doesn't say it on here, but it's a number 30 short. So remember, bigger the needle, bigger the number, smaller the needle, okay?
Do you ever have a number 30 long?
I haven't seen a 30 long. There are some 30s that are just standard 30s, but it won't say long. Just because when they're really long like this, it needs to go into a block area, and it has a lot, and I'll show you on Toby here, it has a lot further to penetrate. And if it's too thin, the needle would break into the mouth because you're going to go past bone. So typically it's not going to be a 30 long per se, but it will be a little bit, it won't be called a 30 short. It'll just be called a 30. So which means it has probably about 1/8 of an inch more added to it as opposed to it just being 1 inch long. So, a good question. Another thing I want to introduce to you, we'll talk a little bit more about it on Monday during lecture, the different types of anesthetic. A lot of times doctors will use what we call lidocaine for patients, and those patients will typically not have any heart problems or any kind of anxiety issues because it adds a lot of epinephrine, which can make the heart feel like it's speeding up a little bit. So if they do have any heart problems or complications, they'll use a carbocaine 3%. Some doctors will typically use carbocaine on the upper anesthetic injections just because it's a little bit short lasting. And again, remember when we're doing any injections on the top, it's for each individual tooth. Whereas for the bottom, it's an entire block, so you need it to last a lot longer because you need that whole entire half of the area to be completely numb, correct? So I'm going to ask you where we place things in just a moment. So if we were to do a setup for a lower injection, we would have a yellow needle and lidocaine, and they're color coded. Again, we'll talk a little bit more about that on Monday. But red is typically lidocaine, okay? So you would kind of have that set and that set for either you to put together or doctor, just depending on who likes to build their anesthetic syringe. If it was for an upper, most likely you'll have a carbocaine and a blue together, okay? If they're doing both the upper and lower at the same time, then you just put them all out together. Because sometimes a doctor will work on one side. Remember, you cannot work on what? Yep, you can't work on two bottoms, but they can work on uppers on either side, or they can work an upper and a lower together. And why can't you do the two bottoms together?
So you could bite yourself.
Yep, the whole jaw will be numb. And so if the whole jaw is numb, then you can bite yourself. Because remember, one injection numbs half of the mouth, so if you gave another injection here, this whole entire area is going to be numb, which causes the patient to have no control of the tongue, swallowing, and they're biting and talking and slobbering and everything sounds crazy, right? However, if it's an upper and a lower, they're just going to talk a little crazy, just half way crazy, you know? So it'll be like that. So what I want to show you, anyone want to try building the anesthetic? I mean the carpio in the syringe?
I do.
You do? Okay. You want to too?
Yeah.
Okay, so I'll have you build and then we will show you how to dismantle it. And we are going to do it for an upper. So, for an upper injection, we will use those two. And are you building for me? Okay, and then I'll have you build for lower when she's done.
I'm trying to remember. If you said there was either you put this in first or that one, but you said it both ways, so then I think I'm kind of confused.
Yep. Yep. And what's going to be the most important?
I'm confused. I don't remember.
Okay, so then I'll build. Do you think you remember? Have you read through your CAL to practice and watch the video?
Well, I feel like I remember because I saw them do it at my endodontic place a lot. But
Okay, so you want me to show you again? Okay, I'll show you again, and then I'll let you practice again before we have you build in front of you. So remember when we're placing in the syringe, right? Typically you want to hold it into your left hand. If we're doing an upper injection, you're going to twist this lower part off of the needle. You're going to immediately go with the fulcrum, right? So that way you can put it into the threading portion. And when you're screwing it, you want to hold your fulcrum so that you have control of how the needle is placed onto the syringe, right? You put the needle on first because, again, you have a better chance of not bending the needle once the carpule is added into it. You now retract the harpoon and piston by using your thumb and pushing and pulling back at the same time. You want to slide in the carpule, making sure that the rubber end is at the bottom where the harpoon is. If you put it in this way, you're going to break it and it's going to crack and it's going to possibly cut yourself. We have on PPE, right? We're pretending so. So you want to make sure that the rubber stop is at the bottom. It comes in, and I would slide it up to the needle first. Then I let go of my harpoon. I bring it upside down, tap, tap, and then tap, and then you place down, right? So it's all about making sure you have really good control. You never have to rush. You never have to go super fast. You never have to do anything fast when it comes to your health and the health of your patient. So if you need to take your time to put it together, you can just make the doctor a little pissed at that moment. It's okay. You know, they'll kind of give you a little frown, but you know, you don't want to stab yourself, right? So it's okay sometimes when they get a little bit grumpy with you. You just want to make sure that you're being careful. You never want to do it exactly over the patient's mouth at all, just because people might get nervous when they see that. So typically you build your needle, because sometimes you have to change the cart if you're going from upper to lower with your back away from the patient. If they're like, oh, can I see it? Typically you'll say no. If they really insist, then you can show them, but I always take my needle completely off. I will unscrew it and show it to them, because for some reason they see that little tip on there, they think it's just even bigger than what it is. If it's a patient, a young child, I will unscrew the needle altogether and not even put it together and let them hold it and say, see, this doesn't hurt, this is what's going to happen. Okay, and then they're holding it and touching it, they're feeling it, they don't feel the needle's not on there, so all they're feeling is the threaded part, which is blunted, right? So they're not afraid of it, they're not scared to have this come towards them, so when they're looking at it, they're like, oh, I seen that earlier, I touched it. So sometimes you have to do it that way, but typically the doctor will have them look away, look towards, and they'll kind of hold it over here on the back of the chair. Have you ever seen this? And then they'll start shaking the cheek, and then they'll come in this way, and then they'll, you know, hands usually kind of blocking the eye, so then that way they're not seeing exactly what's going on. So with all that being said, I'm going to show you placement of the topical anesthetic. Do we know what the topical anesthetic is used for?
it's to numb the gums before you use.
Yeah, it's like a pre-numbing agent to help numb the gums. And the best way to help pre-numb the gums, and we're going to pretend our Vaseline is our topical. So you just take out a little bit, put it on your 2x2. You'll have a cotton roll as well. And you, as the assistant or hygienist, the hygienist can get the patient numb, the assistant cannot get the patient numb, and then the doctor can. So the assistant will set it up for the doctor or the hygienist to come in. So depending on what tooth number you're working on, we'll call this tooth number 8. If they're working on tooth number 8, you would then take your 2x2, a little bit. And then, you know, of course, you're explaining to your patient, okay, looks like we're going to do a filling for you in number 8 today. What I'm going to do is go ahead and add a little bit of topical anesthetic to the gum area, just to kind of get the area pre-numb before we actually give you some anesthetic. Do you have any questions about this? They'll say yes, no, whatever. You check their health history, medical history, make sure whatever it is that you're using can actually be used on the patient. And then if everything's a go, then we just go for it, right? So in doing so, you want to kind of pull the lip a little. And then you'll say, go ahead and bite down a little bit for me. And since we're working on an upper, it's okay for them to close. So can you hold his mouth shut for me? Okay, so Squeeze it for me. There we go. So then you would pull the lip back, and you're going to dry right above number 8. You need to dry that tissue off, removing any of the moisture there. And then you would take your topical anesthetic, and remember we're doing an infiltration, so it's going to go directly above number 8. You'll have them close together and just hang on to that, and then you can hand them the saliva ejector, because sometimes the flavoring kind of drips, especially if it's on the lower or in the back, and then they start gargling and making noises, and they're like, "Can I get suction?" And you know, some of them won't swallow, so it's dripping down their, you know, bib and stuff. I've seen it all. And so if you give them the suction ahead of time and just say, you know, if you feel any kind of saliva gather up, just go ahead and put this inside there and wrap your lips around. It's still going to allow to get the area pre-numb. Okay, so then that would be how you give anesthetic in any of the maxillary teeth. You're placing the topical anesthetic directly over the tooth that you're working on. Any questions about that? So when it's time for me to do a check off with you and I say, okay, we're going to do tooth number 13, I'm going to be watching to see what you're placing. I'm not going to show you palatal injections or anything about putting topical on the roof of the mouth at all, because as you guys enter into the profession, they will show you exactly where nerves run for blocks on the palatal part. Right now, I'm only going to be looking for infiltration topical placement, okay, and lower blocks. So if it's a lower tooth, and I say, okay, we're going to do a filling on tooth number 18, then I'll show you where I want it placed. If I say it's 30, I'll show you where I want it placed. There's only one area for both of those, except for if you do, no, I won't show you that one. So we'll just worry about the blocks for right now, okay? So any questions with that? Okay, so then, yeah.
How long do you leave that on before you actually get the shot?
Just depends on when the doctor's coming. Typically, once you get the patient back, within the first 10 to 15 minutes of taking health history, talking, explaining what's going on, checking x-ray pictures, if you place that during that time after you're done getting the information you need, the doctor or hygienist will have entered the room. Sometimes you have a little signal, you can let them know that they're coming, but usually they kind of know the schedule. So about 10 to 15 minutes, they're entering the room, and now they're coming to give the injection.
So you leave that in their mouth for 10 minutes?
Yep, until the doctor comes. Yep. 10 minutes is really good. 15 is kind of long. It means if you need to go check on the doctor and figure out where they're at and what's going on, they might be a little bit behind. But I still would leave them in place just so that it stays there and continues to stay pre-numb. It's not going to be numb, but it's going to dull-in the feeling of the needle as it goes into the tissue. Okay. And so when the doctor comes to give anesthetic, the assistant is sitting on this side typically, and the doctor, most of the time I've experienced, removes this out. Then you take your suction and you just kind of do a little bit of suction. You don't need to do a rinse in there at all. Just add your little saliva ejector in the corners of the mouth, have them close a little bit, and then while they're doing that, the doctor will come in and then they will get ready to do the actual injection. Most doctors I've worked with will remove it and uncap it themselves. I have worked with the doctor that likes you to uncap it, but remember, you guys will not be uncapping it for me. But if you're ever in that position where you do it, remember what I said. You pull off, you hold tight, you do not let go until you have pulled out, down, and then you release. But we won't practice that here. A lot of doctors, especially the younger doctors that are graduating now, they do most of the anesthetic uncapping and recapping of themselves. So it's okay for you to set it all up over here and let them work on that. A little bit of the older doctors who are now probably 50s and older, they usually like for you to uncap and pass to them. So just keeping that in mind. Okay, if you don't feel comfortable uncapping it, if you discuss that with your doctors, usually they're okay with it. If you think you want to try it, hang on for dear life. Remember, everyone let go until you feel that you have it off and you're ready to go. So in placing it for a lower block anesthetic, so we'll say that this patient, this is the pretending this is me. Now this is where my 2x2, my cotton roll comes in. So in placing it for a lower block, depending on if it's right or left, usually you're going to go back to, it's called the retromolar pad area. And so again, we haven't reached to our head and neck anatomy yet. That word will come a little bit more familiar. But just think of it being retro, meaning being back in the day. Your molar is your molar. It's in the back where your molar is. And the pad, if you were to open up their mouth, is a pad of tissue behind the molar. So get it, retromolar pad. So if you think about it that way, then that's going to kind of help you. So your patient opens up their mouth. We kind of use our little HVD to keep your mouth open, right? There we go. So they open their mouth for you. You have them turn towards you. We're going to work on tooth number 30. You would just take your 2x2 again, and you're going to drive behind where that retromolar pad area is, and you're going to place your topical anesthetic. He doesn't really have a really good one to show you, but I'll do my best. Kind of run. See how this line here runs here in the back part of the mouth? And this is the retromolar pad. It's right here, this tissue that's right back here. Usually if you take the topical anesthetic and place it right on the back part of that retromolar pad and then kind of rub it up against here, then take your cotton roll to help secure it, and then you'll say, go ahead and bite together for me. That will help them to keep it in place. Okay, so then that's what they're doing at that part. That's all you have to do, and the doctor could work on any of these teeth in this lower right quadrant, or if it was on the opposite side, any of the teeth on that quadrant there. Certain offices will have a little bit different procedures for you to do things. Sometimes they like to give another lingual block on the inside, or sometimes they like to go right by the premolar area and add some there too. The doctor will tell you based on their office policy. Right now I'm only looking for the placement for the lowers in those two areas. Okay, confusing? Understand? Got it? Okay.
Are we allowed to practice this on each other?
You won't be able to practice
No,
this.
not that.
Yeah, you'll be able to practice, but you're only going to use Vaseline for it. Yeah, but you definitely can practice on each other for placement. Yeah. You have plenty of time to practice this when you get to hygiene school,
no one's
and
practicing
that is going to be scary. Oh yeah, everyone, you know, they're coming. Oh yeah, when you get to hygiene school, and imagine you being the student, right? And this is your first, your classmates' first time giving anesthetic, and you're nervous. When it's your first time giving anesthetic, you're like this. And you can't stop shaking, and you're sweating, and you're trying to act like you're calm and cool about it, and you're scared because you're like, I'm getting ready to give her anesthetic. Okay, well, now you're scared, and now they're scared because all they see is this going in their face, and yeah, it's scary. So yeah, and then so you would change this needle, right? Because we're doing a lower, all this would come out. Let me show you guys how we take off our needles. You typically always want to take off your needle by the sharps container. Now, if you're working with the patient and you're going from upper to lower, you know, your sharps container will be pretty close to you. The doctor should have one on their side. If they, you know, usually keep a little small red one by their side. They'll dismantle it and put it all together. I mean, take it apart themselves. If it's at the end of your cleaning of your room and you're breaking things down, you want to just come over here immediately and start doing it, right? These stay open sometimes they shut, but have it open so that it's ready to go in there. So the first thing you want to do when removing it is kind of opposite of putting it together. So you want to hold the carpule with the thumb so that it doesn't shatter, and you want to pull the piston. Now this is full, so it's going to be a little bit drippy. Sorry, it's going to kind of spill out because it didn't get injected all the way in there. So if it ever gets caught, if you twist it like this and pull down a little bit, it'll start to come out of there for you, out that heart balloon. So then you retract like this, you pull down, tip out, and place it in there. Keeping that out of the way using your fulcrum, you want to slowly begin to twist to take it off. And before you pull out, you need to bend it, okay? And then bending it so that it doesn't poke you. And then that's really basically how you want to dismantle it, okay? So again, because the anesthetic was still in there, it wasn't really easy to pull out, but when you guys are practicing it, if it does get caught, you just kind of twist it down slowly and it'll come out of the little rubber stopper. Then you pull back, slide down, pop out. Glass goes in here as well. Fulcrum, unscrew, bend, toss, close. 2 points. No, okay. So that is really it for placement of topical and loading syringes. So you have 2 cowl sheets with both of those. You'll need